if you're not metabolically healthy, if you don't do everything else a healthy lifestyle entails, and you just expect me to give you hormones, they're not going to be be miracle workers. Oh, estrogen is our most important hormone, and all that fear around breast cancer has done such a disservice to women. Because, if you were a conspiracy theorist, you could say, well, because, who benefits from a woman not being on hormones, but instead being on 15 prescription medications for statins, high blood pressure, anxiety, depression,
big pharma,
sleep.
Yeah, definitely.
Yeah, so if you think about it, you could just give her one thing, which is hormones.
Hi, I want to welcome you to another episode of the Dr. Dana Show. Today we have a most amazing doctor, Dr. Salome Masghati. And I've learned through the grapevine that she is from, I think, Iran originally, and then moved to Austria, which is a really cool combination, and speaks 5 languages. She is also a gynecological surgeon, and now she's going into functional medicine to really see, I think, basically, if that was me, I'd be like, well, how can I stop the women from going to the surgery? I think that a lot of the surgeons think like this. So I'd love you to talk about hormones. I know you do a lot of hormone balancing and functional medicine today, and some of the problems we're seeing in America today across the board that everybody needs to know these answers, because if they don't, they're going to have serious complications. All right? So I'll let you take it away.
Yes, so happy to be here. Thank you for having me. So I underwent regular MD training in Austria, and then I came to the US. I did some research at UCLA, and then I got into residency for OBGYN, and then I got into fellowship for minimally invasive surgery. I was very, very interested from early on, always about women's health, and going into OBGYN, continued that passion. And fellowship allowed me to specialize into fibroids and endometriosis and conditions that possibly we could discuss could have something to do with hormone imbalances as well, and chronic inflammation. And during that time, I was trained in robotics and laparoscopy with the little keyhole surgeries. And I saw that a lot of women had a lot of issues outside of what I was taking care of them. They had digestive issues, they had inflammation, they had fatigue. And back then, the hormone replacement that I was offering them was merely, a patch, an oral progesterone.
Is that what we call BHRT, like static dosing?
Static dosing. BHRT stands for bioidentical hormone replacement.
Right.
And bioidentical stands for the fact that you're using hormones that are chemically in their structure similar to the human hormones, estrogen and progesterone. Okay. And you can use that, but you can use it in different ways. Before we jump ahead to that, but I just was basing very baseline use of, patch, oral progesterone. That was it. In some women, we even prescribed oral birth control. We really gave it out like candy in some instances, And so that was my conventional training.
That's the same dose every day, right? We're talking
same
about
dose
static
every day.
Dosing. Okay.
Same dose every day. And then with the oral birth control pill, as you know, it's different than bioidentical hormones. Those are synthetic hormones. Yeah. They're oral. They are metabolized through the liver in different ways, and they don't dock on the same receptors as our human.
Are they dangerous? Do you think they're dangerous?
That's can be obviously an inflammatory topic, because a lot of women will take this as an attack on their right to have contraception, which is not at all what I'm trying to do.
Right.
But if you look into the data and if you truly do the research, which I didn't do when I was in residency, I just knew all the things you could use it for, but I wasn't aware of all the potential complications, which is often the case in our medical training. We're not really given all the sides of everything, and you need clinical experience to learn that. When you look into that, you will find that there is potential problems with them for a subset of women. So they're synthetic, so they're not the same as having a woman make her own hormones. They suppress the communication between the brain and the ovaries, so they're disrupting your own communication, and then they can make changes in the brain. They can have changes on the neurotransmitters. They can have changes on peripheral organ systems. For example, they have been associated with higher incidence of gut dysbiosis, IBS, Crohn's disease. They can potentially also change how your skin, around your vaginal flora, your vaginal microbiome, your bladder microbiome. So they can affect that in a negative way. There's also some studies by some neuroscientists, and Dr. Sarah Hill is a great person for that, where they show that it can change our brain. And as a woman, if you're on oral birth control, you might make different choices in terms of your mate selection or who you're attracted to. Wow. And also, obviously, can increase the risk of depression for some women because it can change the neurotransmitters and the pathways in the brain. And we also have some data that it can basically, increase inflammation for some women. And then again, and some of the other things is like it goes through the liver, so you can have higher risk of liver hepatomas. We call them benign liver growths, but it is something that
benign.
They're benign.
You don't want that.
Or prolactinomas, a higher risk of prolactinomas with
I've
oral
had a
birth
bunch
control.
of those in my practice. I didn't know what they were from.
That can be associated with THC as well. There is
really?
a lot of incidents of that I see because a lot of people use.
Really?
So,
THC from marijuana?
Marijuana,
Really?
recreational use.
I had no idea. Thank you for letting me know.
Yeah, so there can be associations like that.
Yeah, so you say that a lot of women want to use these hormones for birth control. I know, and we have it in my practice too. And obviously, you give them consent, and you tell them everything, all the problems that they have, and they make their own decision. But there's a lot of other ways to stop birth, right? I mean, so you would offer those maybe first before the birth control, or
I'm not sure if we really give them full consent, though. The things that I would tell a woman is we know for sure it can increase your risk of blood clotting, in your legs.
Yeah, definitely.
We actually had a family member that we lost because she had some risk factors. She was overweight, and she drove in a car for more than 4 hours without break. But she was on the oral birth control, and she threw a pulmonary embolism, and she died from it. And our whole family has been traumatized by that. Horrible. It was one of my family members. And then obviously you want to explain that to patients, like higher risk of blood clotting. You should also tell them higher risk of nutrient malabsorption, like less absorption of folate, B12. You should be telling them this, but I wasn't. When I was in residency, I barely mentioned.
You didn't know back then. Yeah.
No, I mean, I barely mentioned the blood clots and the hypertension, like the blood pressure increase, but really the other stuff I learned outside of residency.
Cool.
Yeah.
That's wonderful. Let's talk a little bit about BHRT or static dosing of hormones versus the rhythmic dosing or physiological restoration, because I know you're doing that in your practice now. There's not many doctors in the country doing it. And I've heard amazing benefits from this.
Yeah, I was introduced to this through the Women's Hormone Network. That's a nonprofit organization, and they've been optimizing this type of rhythmic dosing, and they have a patent on it, and they work with an exceptional compounding pharmacy that you're familiar with, Harbor. And I got introduced to them through someone called Kristen Johnson, and she has a coaching program. She's a nutritionist. She's incredible, very well known in that field. And then she has a book written together with her colleague Maria Claps. And the Women's Hormone Network has been doing this for decades, and they have a whole website educational course that I took. So I took the course through Women's Hormone Network, and there is a great board of directors there. They have, research going on currently, and
there's a lot of gynecologists on the board of directors, I believe, right?
I think that I'm the only gynecologist actually on board. They have naturopathic doctors, an exceptional endocrinologist who is one of my mentors, and then so they have amazing people on board. Right. To explain how I got into this is that I've been doing hormones for a while for women, but before I got into this, I was doing the static HRT, which means every day you give the woman the same dose. So if you place a patch on your arm, you get similar dosing, about release of the dosing into your bloodstream every day. And then if you take a progesterone pill every night, you're getting similar dosing every night. I also got trained into pellets. I did lots of courses for that. I placed over 500 pellets, so I'm very familiar with them. And I always found that there was something lacking. I wasn't optimizing women. They still had so many complaints. Their serum levels didn't look good. I also got some training into biased and then different methods, right, that people use. there's even a course, there's another person out there pretty prominent in the hormone world who prefers oral estradiol. So I got familiarized with all of that.
Oral, we were always told dangerous. We don't want to any oral at all. No.
Yeah, but there's an argument that these people use in that group that, you know, it does have a better improvement of the lipid profile, like cholesterol, but I don't think it makes any sense because it increases your risk of blood clots. It goes through the liver. Yeah. Most of this estradiol that you take orally gets converted into estrone. It's more pro-inflammatory, and it increases your CRP, which is an inflammation
no, you don't
marker.
Want any of that. No.
But you know, when you go through all of those different trainings, you kind of see all the benefits and risks of everything. Yeah. And I ended up finding out that the Rhythmic protocol made absolutely the most sense. You know, physiologic restoration, that they call it with the Women's Hormone Network, that is what makes the most sense to me once you understand how hormones
it's the most natural to the female body, right?
Exactly, exactly. So I would love for us to dive into that a little bit more. And obviously, I had a lot of questions when I got started, but now that I'm applying it, and I'm using it on myself, I think that it makes the most sense.
You don't look old enough to be doing hormones.
Women can undergo premature menopause, and I've diagnosed a lot of women younger than 40 with that.
Wow, really?
Yeah, I think there is a lot of offenders in our environment.
Yeah, can you speak to that? Like why a woman would have menopause early? Maybe is it from the toxins in the environment, or what's going on with that?
So if you think again what I told you about the oral birth control, you could see the oral birth control as an endocrine disruptor, and we have had a lot of use of oral birth control in the last few decades. We also have, when women excrete oral birth control through the urine, it goes into our water sewage system, and we actually have it in our tap water. We have all these chemicals in our water that can sensitize both men and women to, you know, endocrine disruptors. We have microplastics that we have here in the United States. We have the highest use of all these, you know, toxins in our agriculture. We have, you know, pesticides, herbicides, glyphosate. We have microplastic use. We don't really have a lot of protection through the federal agencies for making sure our water or air quality is very good. Right. I have some hope in the in the future, but we will see how that plays out. And then you have the endocrine disruptors. You have the oral birth control. You have the synthetic hormones. And then beyond that, we have also our nutrition, like the diet, all the inactive ingredients.
Lack of nutrition.
Lack of nutrition. And then you have all these, you know, fillers and dyes, food dyes and all that. Right. And then not to speak of, I don't want to get too controversial here, but there is some data that heavy metal burden and adjuvants in vaccinations can have some impact on our reproductive organs. And then we have had in the last few years a very new vaccine also in the market. And I have seen some associations of that and some studies that show that this can affect our ovaries. And so I have in the last few years seen a lot of younger women with premature menopause or disruption of their hormones. So we could go on forever. I don't know if we will always find all the answers, but what I can tell you is once you're dealing with this and you are misdiagnosed by doctors because you're younger, I'll tell you that is so hard for women because they are not being heard, and nobody expects someone younger than 45 to undergo menopause. So that's that's its own little tragedy there. Yeah.
Let's hear the benefits of the actually explain to the public what is physiologic restoration or rhythmic dosing of hormones versus static, and the difference in the benefits, because I know I've heard huge benefits with that.
So the one issue with the static is that most women on the static are underdosed. They're not getting adequate estradiol levels. When you check women's hormone levels, they're rarely going to be above 80 or 100 picograms. And that's a US measurement. Obviously, in other countries, they use different, but picograms per ml. So that is showing me that they're not getting enough from their patch or their gel. That is usually the FDA-approved version. And so there is a need to give women higher doses than that, because most women, if you actually know what symptoms to look for, they remain symptomatic despite those. Because if you are measuring the success of HRT just by vasomotor symptoms, like hot flashes, you're not going to be addressing the multi-system changes that happen in
Sure.
the body.
Right.
So hot flashes can be treated with the smallest amount of estrogen. That
Well,
doesn't
with
mean
we can do it with herbals and
with
homeopathic.
herbals.
Sure.
Exactly. So that cannot be an indicator for how successful your HRT
What is?
is.
What is?
So, for example, if you look into mood or joint pain, right, or sleep, you will find that women rarely get adequate symptom relief if their estrogen is below 100. Then if you add to that you are now giving a static progesterone every day, you're counteracting the effect of estrogen because you downregulate estrogen receptors further. So not only are you not adequately dosing them, but you're downregulating the receptors for it.
Right.
The receptors are basically the molecules that allow the hormone to enter the cell. Without the receptor, you can have a lot of hormones floating around in the bloodstream. If it doesn't get taken up in the tissue, it's not going to perform its function. So you have that. And so from that standpoint, and also from the fact that the natural rhythms, the peak and troughs, those ebb and flow of estrogen and progesterone also have other functions than just what I talked about, then it makes sense that static is
For
inadequate.
estrogen, I've always heard heart and brain are so key, especially when women get older. So many heart attacks in the 50 to 70 range. It's like it goes up exponentially. And also their brains just thrive on estrogen. So what's the number that you want to look for a peak estrogen value?
And then let me first explain why the peak makes sense. So if you go away from statin and you look at Rhythmic, what you're doing is you're imitating exactly how the hormones operate when a woman is naturally cycling. And that has significance beyond ovulation and fertility because it affects all your organ systems, right? So as estrogen goes up in the first half, you're getting cell growth. You get all the stem cells activated. You get your brain cells activated, your bone cells activated. The bone is not a static organ. It's not just a mineralized,
breaks
bone
up and builds up and breaks down, builds up
constantly breaks down and builds and breaks down. And you want the bone to be as metabolically active. So as estrogen goes up, it stimulates the osteoblast. It stimulates tissue growth in the breast tissue. It makes your collagen grow in the skin, in the hair. It makes your brain, develop new brain pathways.
It makes you like Marilyn Monroe, right?
Yes, it makes you, gives you all the good things that you want. It makes you, be invincible when you're working out. It makes you control your appetite better. Your digestion looks beautiful. Your digestive enzymes are working your natural, stomach acidity. Just it affects every single organ in your body. But then the body has this incredible safety mechanism. I mean, how can you not love biology? It's incredible. Then estrogen reaches its peak. And the body goes, oh, cell rest now. We got to stop too much growth, right?
Yeah.
Let's stop the cells that grow, but they were dividing, but they're, they have mutations.
Right.
They have DNA damage.
Right.
Let's get rid of those. So it initiates something called apoptosis, gets rid of those cells. So that peak has that function. If you never achieve a peak, if you always have the same levels, you're not getting that incredible function of estrogen. And then estrogen drops a little bit and then goes a little bit up again in the second half of the cycle, and then progesterone peaks. And progesterone peaking is like the janitor coming in and sweeping out again all the old dead cells, autophagy, apoptosis, like it's incredible,
Let's
right?
slow down a little bit because a lot of the people watching this aren't the physicians.
Yes.
So autophagy is basically fasting. It's the body is detoxing itself, right?
Yeah. So the progesterone peak stimulates something called apoptosis, where you have programmed cell death. You want the cells that are no longer of purpose to your body to get out of your body.
Exactly.
So when you get growth from estrogen, you also want to have arrest of the cells that are not healthy.
Okay. Will that help with senility, like the special?
So senescent cells are being removed every month in a woman. A woman that is cycling, whether she's in menopause or premenopause, if she imitates those hormone rhythms, she's doing the maximum that she can do to take care of cancer cells, to cleanse her body. Right. It is the most natural way of doing that. Okay. So once a woman understands that the peak and trough makes sense, she's more inclined to want to do this, because one thing that we talked about before we started recording is one of the things that happens is, as a side effect of this, it's a byproduct is that you're going to get shedding of your uterine lining every month too. Right. So you're going to be having periods. Right. And a lot of women go, well, I was finally happy to not have periods again. Are you telling me I have to deal with this? And so I think, first of all, it can make a woman feel young, still having periods. It makes her feel like she's still living, she's still, functioning in the way that she was when she was in her 20s and 30s. Not that because I'm glamorizing being youthful in that sense, but having a cycle means that you got enough hormones on board to build the tissue systems in every other organ. So you can't get that if you're not also built the uterine lining
Well, it will
up.
glamour. I mean, it is glamour. They're going to go back 10, 15 years, and their skin is going to be amazing. Their collagen's going to be building. And so wouldn't you want all that?
But you're doing it really for the health span. So you want to make sure, you're not frail. You're not having 5 heart attacks by the age of 65. You're not completely, insomniac, lying in bed. Your marriage falls apart because you no longer know who you are. You feel disconnected from your husband. You can't tolerate your kids anymore or your grandkids. You can't perform at your job. So it has so much more function. And I honestly can attest to how powerful hormones are. I don't think I understood it until I went through it myself. So being younger but still going through it yourself, I think it helps you have more empathy for people that
well, you're obviously an authority, and now you've used them yourself, so that's amazing. So
yeah, I do.
That's good. Talk a little bit about, is there research? Because I've heard from 2 different camps. So with the static dosing, we had research. I thought we had research. I didn't read it, all of it myself. And now with the physiological dosing, I know there's new research. So I think a study from Denmark for heart disease possibly. And then what about osteoporosis and bone density and, and stroke and reproductive cancers? Can you speak to any of those?
So we have some studies, not necessarily as much the physiologic levels of hormones we use with PR, but at least rhythmic, so cycling progesterone. And the data shows that if you cycle progesterone, and that's not even adequate, like as high of estrogen levels that we get. So it's you could take those results and multiply the positive effects of it if you wanted, but at least those results showing that bone health or bone density benefits from cyclical progesterone.
And when you say cyclical, you're talking about using different dosages on different days and actually taking it twice a day, right? So it's a large amount.
So it depends on bioavailability and distribution of something that you use. So if you're using a cream and the half-life of it, it should be used twice a day with the dosing that we use in PR. But if it's an oral progesterone, it can be used once a day. So it all depends on which form you use. But the main thing is we're not using progesterone every day. We're using it only 14 days after cycle. And we like to keep a cycle at 28 days because that's in line with, the lunar cycle, and that's the optimal duration of a menstrual cycle.
Right, you mimic exactly the cycle.
You mimic, and I think something that I don't get to talk much about, and I should talk more about it, a woman has an infradian rhythm. So a woman has a circadian rhythm, just like every human, man have it, and animals have circadian rhythms. But women, in addition to men, have something called an infradian rhythm, and that is related to their menstrual cycle. So women's body responds to rhythms outside of the 24-hour circadian rhythm.
You mean like lunar, like moon?
Yes.
Calendar?
Can
you explain that? That's really
so
cool.
it has to do with exactly what I talked about, the peaks and troughs of estrogen and progesterone, sets their body up for a rhythm that's a 28-day rhythm. So if you give her the estradiol and progesterone in that rhythm, that's what her body was used to most of her life. So you're giving her back what her body was used to with that infradian rhythm.
Nice. So that's very interesting. So, I mean, I've always, because, we were in naturopathic medical school, and there's a lot of different things people were doing, but the lunar calendar or the moon itself, how does the moon work with the female body? I don't understand that. Like,
I'm not sure I'm an expert on this, but I do think that we have some data that, for example, women can sync their cycles to, if you put a lot of women together in groups and they work together, they often cycle their, they sync their cycles together.
Cool.
So I think there is multiple things that we are usually ignoring when we're trying to function in modern world where we're exposed to, modern life demands with the blue light and the hard work hours and all of that. So we're disrupting our circadian rhythm. And if we take an oral birth control, for example, when we're younger, we're disrupting our infradian rhythm. So we're disrupting these pathways, that connection to nature. And this is not to make people feel guilty. This is just to know that those things exist and that you can address it or at least imitate it with the type of hormones with PR that we use.
Okay.
Yeah.
I mean, everything that you're talking about and other interviews I've done in the last few weeks and just in the last month, it's like just completely going back to basics. Everything has to go back to basics, like fertilizer, real fertilizer, and no chemicals in our food. You know, the whole, I think it seems like everybody's standing up right now for this. So it looks like a really good time.
I love this. Yeah. Yes. I think a lot of mass awareness is happening and people are waking up more to what could be the best for their health.
Totally. I agree with you, and I think we're going to fix a lot of problems, although a lot of damage has already been done. I'd like to speak to, I do a lot with thyroid. I kind of specialize in thyroid pathology. So I want you to speak a little bit about how women's hormones or physiologic restoration works in combined with, you know, subclinical hypothyroidism that we're seeing across the board and what you've seen in your patients with that. I think we need to get that out to the public.
Yeah, so a lot of women undergoing perimenopause. Perimenopause is the phase where your hormones start changing, but you're still cycling. And then menopause is basically, the definition is your last menstrual cycle, and then you no longer have that. So menopause is really more of a static, like one point of like, that was it, you know, versus perimenopause is the duration before that. Thyroid actually changes in that. So it slows down a little bit. A lot of it is impacted by the changes in progesterone and estradiol. So they do impact thyroid function. Also, the conversion of the pro-hormone T4 to the active hormone T3 can also change because that enzyme that does that can slow down with age as well. But as we both know, there's a lot of contributors other than, you know, the sex hormones changing and the adrenal function changing, like cortisol being underactive or overactive can affect the thyroid. You also have nutrient deficiencies, and we all know, like, nobody really eats iodized salt as much anymore. But, you know, iodine, especially in the areas in the United States where it's like Midwest, in away from the coastal areas, there's maybe not as much consumption of seafood. There's maybe a little bit of under eating iodine, and if you listen to the work of Dr. David Brownstein, he thinks everybody should be on iodine supplementation if they have thyroid dysfunction. But you also know that in our waters we have fluoride and chlorine, and both of them are halides, and they have the similar chemical charge than iodine, and so they can disrupt it. And then bromide is an additive in baking goods in the United States, not in Europe, but here.
That's very interesting. There was a story about like a 12-year-old boy who was having a lot of symptoms of hypothyroidism, I mean, full-blown hypothyroidism, and nobody could figure it out. He was on sports teams, and his coach was everybody's looking at this kid going, what's going on with him? He went through every test, everything. And then one old doctor said, do you drink soda? And he goes, yeah, I drink soda. He goes, what kind of soda? Orange Crush, right? If you look on a can of Orange Crush, bromine, he's drinking like 6 Orange Crush a day.
Wow.
It completely, tells
disrupted
you exactly
his thyroid.
that, so that was taking the place of the iodine. Even though he's getting iodine in his diet, it wasn't doing anything. But 12 years old, you don't have a hypothyroid for 12,
Yeah,
so.
yeah. And a lot of people, the water that they drink is not filtered, and then, the food we eat might be deficient in nutrients. So there's that, zinc, selenium, iodine are important nutrients. And then I believe heavy metals can impact the thyroid as well. Like there is some data on that.
Yeah, totally. That one is very interesting because what I've come to the conclusion of, you definitely you could have lack of thyroid hormone, you could have lack of conversion, but what if you have enough T3 and it is converting, but it's not getting into the cells because there's so much inflammation in the body.
Correct.
So like insulin resistance,
blocked,
talk about hormone thyroid resistance. I think that's the biggest one we're running up against these days, and not many people understand it. And then when you look at the labs aren't that much different a lot of times. And the big problem, I just want to hit the bandwagon here a little bit for TSH. If your doctor's only running a TSH on you, they need to do a lot more labs than just TSH. And TSH, in my book, after a lot of years, it's 1. I say 1. TSH should never be over 1. And free T3 should be 4 and above. Those are the patients that feel great. They're multitasking. Almost all my patients are women anyway, so they're taking the kids to band practice. They keep everything in line. They're the matriarchs. If they weren't there, the whole family wouldn't be there. I mean, but when the thyroid goes, everything goes. It's amazing. It's horrible to see that, but we can fix it.
And estrogen is so important for thyroid function in terms of when estrogen goes down, we're more prone to autoimmune diseases. And one of the things that can happen is we're more prone to, first of all, we have less stomach acid. So we are more prone to having gut dysbiosis, which then can increase our risk for Hashimoto's autoimmune disease. And then also estrogen itself is immune suppressive. So Hashimoto's can often flare, or people are newly diagnosed with it when their estrogen levels are going down. And that attacks the thyroid. Those antibodies, those are basically warriors or soldiers that think they should attack the thyroid instead of, something
Right.
else. And so we lose thyroid function for Hashimoto's. And that is something that is very common in women in perimenopause and menopause. I
Nice.
mean, women have a higher percentage of autoimmune diseases than men the moment they reach perimenopause and
Really?
menopause. Women are usually doing health-wise so much better than men all their life until they reach perimenopause and menopause. And then they become, higher risk for Alzheimer's, 70% higher risk than, men. They become more hypertensive, cholesterol goes up, they have more higher risk for heart attacks, autoimmune diseases, bone density loss, but none of that happens when they still have adequate estrogen on board. So estrogen is our most important hormone, and all that fear around breast cancer has done such a disservice to women.
Yeah, that's very
Because,
interesting.
if you were a conspiracy theorist, you could say, well, because, who benefits from a woman not being on hormones, but instead being on 15 prescription medications for statins, high blood pressure, anxiety, depression,
Big pharma, yeah,
sleep.
definitely.
Yeah, so if you think about it, you could, you could just give her one thing, which is hormones, and she
Right.
wouldn't need all of those
Well,
prescriptions.
what's your thought? Because I heard a speaker, actually a gynecological surgeon who is now doing functional medicine at A4M. I don't know if it was this year or last year. And she basically said that if a woman's diagnosed with breast cancer and she doesn't have hormones anyway, because most breast cancer happens, after 40 years old, right? It happens in menopause. Because you don't
Correct.
see, and it's, all right, this is twofold. You don't see females who are cycling in their 20s and 30s when they have 550, their estrogen's 550 and it's as high as it could possibly go. They're not really getting breast cancer, right? So why is estrogen, if it is such a big deal, why do menopausal women get breast cancer when their estrogen's very low? It doesn't make any
Yeah.
sense. So
Yeah, because what happens is when our ovarian production of estrogen goes down, our fat cells take over and they produce estrone, and generally we become more pro-inflammatory. So everything else changes. Our gut health, we become more pro-inflammatory, our adrenals are out of whack, and then we're just more susceptible to any kind of, external environmental toxins as well. And then also, a very big argument has to be made that when estrogen declines, you no longer have the positive effects of estrogen on the breast tissue. In fact, we have studies from the 40s and 50s and 60s up to when tamoxifen, which is a selective estrogen receptor modulator, before tamoxifen was invented, high-dose estradiol was used for breast cancer because it actually suppresses breast cancer. And they use it in form of DES, diethyl, oh my God, it's a synthetic estradiol, which had other risks, but they also used estradiol injections. So so there is some data on that and nobody talks about this. And then tamoxifen came and then it became like a patented product that you could market differently for pharma, and nobody talked about high dose estrogen for breast cancer. We also have good data from some Scandinavian studies that if you give someone with breast cancer something like an aromatase inhibitor, so you're blocking estrogen in the breast tissue, but you give them systemic estradiol, you're not increasing the recurrence or worsening the outcome of the cancer. And then there's some data that after you've had breast cancer, if you reintroduce hormones, that also doesn't increase your risk of recurrence. So this whole argument of estrogen, we're missing a lot here.
Yeah,
and those studies are not going to be done because there's no interest.
I know. But the point she was trying to make is this is like giving them suicide practically, because they're going to be so depressed. As soon as you get the diagnosis of breast cancer, most people think I'm done. I mean, some don't, and then you can't even give them hormones to help them with their mood, help them with anxiety.
Exactly.
And she was really on the bandwagon, and I love that lecture, something I always remember.
Yeah, well, if you think about it, I talked about how the estrogen peak induces apoptosis and cell arrest. So that's the best mechanism of taking care of the mutated cells, of the
Yeah.
cancer cells. And then again, having a progesterone peak in the second half also stimulates TP53, which is a tumor suppressor gene. So if you're having adequate hormones on board, which is when you're in your younger years, you're at lower risk for cancer because you're generally doing better job taking care of defective cells. So we're looking at it the wrong way. And then all the studies that were done and looked into breast cancer, they were using synthetic hormones. They used conjugated oral estradiol, estrogen.
Equine, right? Equine from
which is
horse's
from...
urine. Yeah.
And even that study, even if the worst quality of estrogen, the risk of breast cancer was not increased in the estrogen alone group.
It was very, very tiny bit. And they actually had benefits. Some groups, some age groups had benefits, really. So it's not the estrogen. Yeah.
It comes down to getting the oncologists on board, the breast surgeons, everybody being on the same page, because I can tell someone as much as I want. If they only hear it from me and not their 9 other 10 other doctors, I'm not going to have a lot of, influence in her life.
Well, you're right, but there's a lot more proactive patients coming around now, especially when just in the last 2 weeks or the last couple of months, but the last 2 weeks especially, with all the new information coming out everywhere, because people aren't as afraid anymore to say what they've seen. They don't, oh, I'm going to get suppressed or I'm going to get destroyed my career. No, they're not that afraid. They're standing up for what they believe in, and they're giving the public the choices that they need. And that's why I brought you on here today, and that's why I do these podcasts.
And I love that you brought up choice, because even if you don't believe anything I said about estrogen and breast cancer, at the very least you can make your own decision in terms of how much is this treatment impacting my quality of life and what am I willing to risk for this, right? So, for example, do I feel that my cancer treatment is completed by surgery and radiation and chemo, or do I need to be also avoiding hormones, which then impacts my risk of heart attacks? Did you know that cardiovascular disease is the second highest risk for women to die from when they have breast cancer? So if someone has breast cancer, if they survive the cancer, their risk of dying comes from a heart attack. So then you should, all weigh the risk of benefit of withholding hormones from these women. And I feel so bad because they didn't choose to have this diagnosis and them being, in that situation. I really think we need better.
But someone like you has all the answers. You are not all the answers, but you know what to tell them after all being a surgeon and now doing functional medicine. So you can give them the ramifications of if you do the chemo and radiation, well, you might have a heart attack later, and you could show them the data, you could show them the research. That's key. That's all doctors have to have this knowledge, or they should have it.
Yeah, and obviously we're not there yet where I would give them hormones while they're actively undergoing treatment, just because that would be, in the current state, that would, cause a lot of friction with their, physicians that are taking care of their cancer. But it's definitely a conversation someone can have
would you
after
use
they've completed
maca?
treatment.
I mean, would you use maca though? When they're under, I would. If they're under cancer treatment for breast cancer, you could use maca. There's plenty of herbs, and as naturopaths, we have, a lot of herbs we use to help the different cancers and and keep those balanced. I mean, maybe you're not getting the same as a physiologic restoration, but at least you're getting enough to take the anxiety and depression away, and your brain can actually function, and you can understand what your oncologist is trying to get you to do. I've seen menopausal women where they had worked themselves over COVID. They worked so hard for so many weeks, and they hadn't had their hormones. They ran out. And one woman called me, and she's like, "Hello, Dr. Churchill." I was like, "Who is this?" And like, "Dr. Dr. So-and-so, what's the matter?" "Oh, I ran out of my estrogen, and I've been working on COVID." She was MPH. Imagine being an MPH, health, and the work was, and I couldn't believe it. And we gave her the estrogen, and she called me a week later and says, "Oh, hey, Dr. Churchill, how you doing? I feel great again." It showed me the benefit for brain. I mean, that was the one thing you have in your life. It's just like that was a major pivotal moment I saw estrogen in a woman's brain, because obviously I don't have that. So it was really cool.
Yeah. No, the problem I have if just telling women all you can do are supplements is that we're not getting this multi-organ benefits that estrogen does. We just don't. I forgot to tell you earlier too, when we were talking about cycling progesterone, there's some data also, because you talked about brain function, that you have better plaque removal from the brain if the progesterone is cyclical and not daily. So you have some data showing that cycling hormones and using rhythmic hormones has benefits for you. But we definitely would love even more data. We have anecdotal data. We have doctors in our group that have been using this for 15 years and longer.
Themselves?
On their patients.
On their patients, okay.
And they haven't seen any increased risk of breast cancer or uterine cancer, all the things. In fact, they have all these women in their, my mentor, he has women in their 60s, 70s. They're still cycling. They love it. They feel young. I had this patient telling me, Dr. Masghati, I love it so much. I went hiking. I've been traveling.
Wow.
I love my sex life with my husband.
How old is she?
She was 75.
Wow.
She wasn't even the oldest. She's not even the oldest in the practice.
Yeah.
She loves having her cycles because she understands her cycles mean that she's getting enough hormones for all their other organ tissues. She's so functional. Obviously, you want to combine this with a healthy lifestyle. You don't want to just use hormones and sit on the couch, drink Coke, and eat fast food. You want to eat healthy.
Well, but I don't think
you
can. When your hormones are all activated and they're all at the levels they're supposed to be, you can't sit on the couch.
Oh my God,
you
can't.
Want to.
You
You'd
have
be
so
too,
much energy.
I gotta get out of here. I gotta go traveling. I gotta do something.
I gotta travel. I want to meet with my friends. I'm social again. My oxytocin levels are better because now I have estrogen on board. I want to have sex.
Talk about oxytocin. What does that do?
So oxytocin is the love hormone. We release a lot of it when we are when we have a newborn that we hold, that we smell as a mother, when we breastfeed. It's also, we release that when we cuddle our partner, make out, when we make love, when we orgasm. And oxytocin is dependent on estrogen. When estrogen goes down, a lot of women lose oxytocin. So they don't have the same ability of orgasming, feeling connected with their partner or the people they love. So bringing estrogen on board helps them with their oxytocin. So the woman feels like, I want to hang out with my friends again. I actually want to sleep with my husband again. Maybe I'm not going to divorce him. Because a lot of divorce rates happen right around perimenopause and menopause. And I'm going to be honest, I see some people use that as an argument to say, well, that's who you truly are anyways, and now you're going to live your fullest truth. I don't think that when I underwent perimenopause, I was living my fullest truth. I was living my worst version of myself. I couldn't focus. I had word finding issues, brain fog. I couldn't I couldn't think fast. I didn't have any libido. I didn't have any energy to work out, and my appetite was dysregulated. But when estrogen is on board, it controls the anorexia, like the appetite centers in the brain. Okay. You actually don't want to eat as much anymore. You don't want to eat unhealthy foods anymore. You want to work out more, and you want to have sex and be connected with your partner, and your brain functions. I couldn't do what I do if I wasn't on hormones. So I don't know how other people do it. I have a lot of admiration for people who make it through this, but I personally chose not to optimize my health with them. So
we've seen huge benefits just from static dosing. I guess I've probably done that over 10 years, and just the benefits of that. So then just fast forward that to the physiologic restoration that you're doing and other doctors. That's really amazing.
What happens with static is that initially it makes the woman feel good enough, but after a while, because you're not respecting the natural pulses and rhythms of receptors and how they work with each other, you are going to get breakthrough symptoms again. So hot flashes come back, or joint pain comes back, because suddenly it's no longer enough. Because as I said, the levels are inadequate. And not only are the levels in absolute terms inadequate, the estrogen and progesterone are not given in a way they were meant to. They're yin and yang to each other. They weren't meant to be always given in the same dose together all the time. They're supposed to have those peak and troughs, the ebb and flow. Everything in life is rhythmic. If I gave you your favorite pie every day, you wouldn't want it anymore. Neither do the hormone receptors, right? They need that pulsation, that rhythm. And so static works for a lot of women initially, and then they run out of steam. And that's where they come to someone like me, where they find that they're no longer optimizing their hormones.
One other thing, we can talk about other things, but I want you to talk about osteoporosis, because in elderly women, or men too, that's one of the things that's the end for them a lot of times. Once they break a bone, they go in the hospital, they never come out. So this is something that's hugely important, and they're not going to be traveling all around the world and doing all these things if they think they're going to step off a curb and break an ankle.
Correct.
So talk about osteoporosis and well, not just the hormones, but in general, what your take is on that and how we can help them.
Yeah, so we know that we have now a longer lifespan, but not necessarily a longer health span, right?
Okay.
So we might live longer, but we might live a lot of those years unhealthy with broken
Right.
bones or, frail. And you're right. And so what is definitely true is that we know that we reach our peak bone mass in our younger years. And there's something called musculoskeletal syndrome of menopause, where as we age and reach perimenopause, we lose muscle mass. And with that, we also lose bone mass. And so a lot of women have to work harder to maintain muscle mass, do exercises that can help the bone. And they also, we know that as estrogen goes down, directly that affects the osteoblasts and osteoclasts, which are the cells in the bones. And estrogen and progesterone together keep that bone metabolically active, so it constantly recycles itself. When they go away, that bone becomes more porous and more static. It's no longer metabolically active and it breaks faster.
Okay.
So definitely so much higher risk of osteoporosis after your hormones go down if you don't replace them adequately.
So doing that, but also you'd recommend, like light weight training, strength training, and what would you recommend for women to get enough calcium, or do they need to take calcium, or how would you get the calcium in their body, through food or?
So quick correction, not even necessarily lightweight training. You can ease yourself into lightweight training, but you probably need a certain amount of resistance and repetitions in yours to not lose the muscle groups. I didn't even know that. I wasn't taught this in med school, but it's a little bit harder than you think to actually maintain the muscle mass, right?
Sure.
So it's not going to be just your weighted vest and walking. I mean, walking is great, or being on a stepper, but you'll need to do a little bit more to not lose that muscle mass. And that's going to be resistance training targeted. In terms of calcium, I recommend dietary calcium, because I also recommend animal protein. So if you're going to be taking animal protein and you eat cottage cheese or goat cheese or, dairy or yogurt, you're going to get calcium from that. And then I love animal protein, like red meat, pasture raised, things like that. And so that, and then you definitely need magnesium for the bone. There is good quality data that a form of vitamin K, MK7, is very helpful for the bone because it helps the calcium to be deposited in the bones. Vitamin D is important because it helps the absorption of calcium in the gut. So if you eat it in your diet, you need adequate vitamin D to absorb it.
How much D?
So that is a topic for a lot of discussion because there's so many different studies. But overall, if you're not genetically impaired or your receptors aren't impaired, you can reach adequate levels. If you get your vitamin D above 50, is it nanogram per deciliters? I think that's a good level to be. You can get it a little bit higher. But I wouldn't be that concerned about toxicity that a lot of people talk about. It's very hard to have vitamin D toxicity. I also recommend sunlight exposure, and then obviously lots of exercise, adequate sleep, reducing alcohol that can impact your bones, and reducing foods that are very acidic or too much like going into some sort of extreme diet, right? Like if you eat spinach every day and have a lot of oxalates, it could affect your bone
soda
health.
is a huge one to
or
leach,
sodas.
to leach out from the
Correct,
bones,
they can
right?
leach. So it's just about extremes, right? If you're going to smoke, you are going to be at higher risk. If you're smoking, you have a high risk of osteoporosis. The biggest thing a woman can do is start estrogen for her bones. I literally reversed osteoporosis markers, like through the bone density scan. I can see it when I start them on adequate hormone levels. So they don't have to start bisphosphonates, because bisphosphonates, these are the medications that the doctors prescribe. So many side effects. And also what they do is they make the bone look better on bone density scan, but they don't make the quality of the bone better.
I didn't know that.
They didn't make the bone stronger. So hormones actually make again, think of the bone as a dynamic organ. And then what's so great is if you do all the things that you need to do for your bones, that's also great for your muscles. And the muscle is an endocrine organ also. It can release substances, hormones basically, that make you feel good. And they can lower inflammation, and it also helps you reduce insulin resistance when you build more. Because it helps you to if you're eating food and your glucose goes up, one of the best things you can do is build muscle mass, because you're going to be able to eat better and more, because you can absorb that glucose into your muscles and metabolize
Got to
it.
get them exercising. That's like maybe the hardest, one of the hardest things. But
I think so. Like, listen, I'm so unhappy here sometimes because if I could, I would bike everywhere. I live in Florida where the weather is perfect, but if I biked, I will probably get killed within 5 minutes with the way people drive here.
Yeah.
But like, I wish I could live like how I lived in Europe, where I would bike everywhere.
Totally different.
I would move. I would constant walk. So a lot of movement came naturally to me because of the lifestyle there.
Yeah.
So women have to understand not only is weightlifting important, but you also just have to get your body moving in general. Like try to walk to your grocery store, try to walk to your local
upstairs,
gym.
downstairs,
Go upstairs,
all that.
like,
Park your car far away, because then if you have a nice car, it doesn't get hit by the other cars as well. So.
Yeah, and movement is one of the best things you can do to reduce your risk of dementia. Helps with blood flow in the brain, and it helps with reducing glucose. Alzheimer is called diabetes type 3.
Exactly.
So if you reduce diabetes risk, you reduce your risk of Alzheimer's. And if you walk, and you actually regenerate brain nerve cells. So I think lack of movement is definitely an epidemic. Loss of muscle mass is an epidemic. Our diet nutrition being depleted of nutrients is an epidemic. And then obviously something that I didn't mention to you, Dr. Dana, hormone use has gone down in the last 2 decades because of that Women's Health Initiative. So it went from 27% of all menopausal women down to 6% of all menopausal women.
Can you speak to that and say why this has happened and that's not true, basically? What the information came out of that study?
You could call it propaganda. I don't know who's behind it, but there was this Women's Health Initiative, and has been debunked since then. It was published in 2002, and it scared a lot of women off hormones and a lot of doctors, and that's how I was trained when I was in residency. Be aware of the Women's Health Initiative. What did it show? Well, they took women that were a little bit older, past the age of menopause. A lot of them, they had some comorbidities. They were overweight. Some of them were smokers. They had different lifestyle in terms of their jobs were demanding, so they weren't sleeping a lot at night. They already had probably some pre-existing cardiovascular risk factors, and then they put them on hormones and said, "Oh, look, they have higher risk of heart attacks when they're on the oral Premature, the conjugated estrogen, and the synthetic progestin they give them."
And
right?
oral as well.
Yeah. And what was interesting is also the breast cancer risk was mildly increased in the group that was on the synthetic progestin and the estrogen, but not in the estrogen alone group. And a lot of people believe that, first of all, it's a negligible risk, even if you look at it in absolute numbers.
Right.
Also, the control group had a lower than baseline risk of breast cancer. That can skew the data because it can make it look like the group that was given the hormones had a lot more. But also, even if you take that away, the synthetic progestins and the oral Premarin are not even the type of hormones I use. We use bioidentical and we don't use oral. So a lot of this is not applicable to our patients at all.
It's all dependent.
Yeah, and then you had all these women who were not generally metabolically healthy. And I'm going to be honest with you. If you're not metabolically healthy, if you don't do everything else a healthy lifestyle entails, and you just expect me to give you hormones, they're not going to be miracle workers and do all the legwork. You have to set the foundations for a healthy body so that the hormones can come in
first, always, especially if they're
exactly.
Right.
So it has to be a holistic approach to it.
The last thing I'm going to ask you can talk about it or not. Where are we going with hormones? I mean, I see petitions coming through my email every now and then, and I hear pharmacies, compounding pharmacies saying, the government or some of the FDA, somebody's trying to take away the hormones, like make them illegal. Is this a real thing, or is this just some? I mean, what's going on with that? Do you know anything about it?
We definitely need good lobbying for our compounding pharmacies. They are such a gift to us, and not every country has access to compounding pharmacies.
Right.
Like, I can't get these creams that I do for myself from my mom in Austria.
Wow.
Compounding pharmacies, there's a lot of lobbying against them because they're a competition to regular pharmacies like
pharma?
Big Pharma and your regular pharmacies. And if you're trying to use bioidentical hormones in the way that I use them, you need to be able to titrate them up and down, and you want to use, often compounded creams, right? Or compounded hormones, even oral progesterone compounded. Because you don't want the food dyes in it, the titanium dioxide that they put in the regular, bioidentical progesterone you get over at your regular CVS. So that's, I think, what the fear is, that a lot of the times these compounding pharmacies are being threatened.
Okay.
In DC, there's a lot of lobbying against them, and I hope we never lose them. And we need to stand up for them because they do such amazing work, and they provide competition, which is healthy market competition.
Exactly. That's what our country is based upon, is competition.
That's exactly.
I mean, if anybody gets too big, like AT&T, or this is just what the government
monopoly,
says, they're going to get broken up because it's a monopoly. But until
they
then,
get to control everything, and we already have monopolies with insurance companies and hospital systems. Us, independent physicians that we're trying to survive here in this big world where we can't be part of a big physician group.
When I was at A4M this year, I'm not going to name any names, but there's people that are very powerful at A4M, and I was asking one of them if I could do an interview with them. And he says, well, I'm going to be here, I'm going to be there, and then he showed me a picture. He was standing with RFK. And it was even before the election. It was just around the time of the election. He's going to meet with RFK. I mean, he's head of A4M. A4M is one of the, if not the major, university there that teaches functional medicine. And I've gone through their system, some of it, and I've taken 10 years I've gone there, and they're like the best I've ever seen. They're really, really good. They're so organized, and their top 5 speakers are genius. It's amazing how much I learned from those guys. So I think we have some big guns, and teaching the government what should be,
be done.
And physicians like us will just fall into place. We'll be the ones that are teaching, maybe even work in those universities. So,
well, I hope a lot of good people get to whisper in RFK Jr.'s ears, because we definitely need an overhaul of the current system. But also, a lot of us that are independent, like your practice, me, like other people, we depend on being able to use compounding pharmacies and not just go through the insurance system. And we work with patients in a complete different way outside of the insurance system. I can take my time for my patients. I can dedicate a lot more attention to them, and that is honestly the best part of being a physician, is that healing aspect. It heals you when you heal others. But if you just have a few minutes for someone and you got to get through as many possible visits as possible, and you just have to type in your computer, and then you have 1,000 codes that you submit to the insurance,
that's horrible.
I can't imagine going back to that. And then what happened the last few years also with forced treatments that we had to take, I cannot go back to that kind of system.
No, I don't think we'll see that again. That's one thing I don't think we'll see again.
I hope never again.
But
I hope
you mentioned
people
that
wake up.
with the insurance, is like you're saying, we can still get insurance covered when they have a PPO. If you just, a lot of times they'll submit the visits, and the labs get covered by PPO a lot of times. So it's not like we can't cover anything.
No, I agree 100% with you. In general, it comes down to, do you believe that what I'm offering you has so much value that it's worth for you to not just go to your regular OBGYN that your insurance covers? And I can tell you, I have helped so many women with different things outside of their hormones too, that I think it's worth it, because I helped you with your inflammation.
Because you're setting them up for prevention. The number one thing is prevention. You're giving them information about the cancer, about the treatments that are being used. You have it. You've taken the time to research that. And this is what a physician should be. I mean, maybe you can't do it for every single modality, but let's say for hormones, you got those answers, and that's really cool.
Correct. Right. So,
Great. Well, it's a wonderful talking with you today, and I'm so glad you came on the show. And we'd definitely like to have you on another time, too. Maybe we can do a specific subject, like vaccinations or something, when the climate gets a little bit better in the future.
Yes, so, I would love that. I'm very hopeful for our country, so hopefully things will be getting better.
Yeah, I am, too. I think things are going to work out, be much better.
Yes.
Thank you, doctor. Have a wonderful day.
Thank you so much. You too.